So again, welcome everyone. I'm Shamia or Mia, for those of you that do not know me, and I am the Acting Viral Hepatitis Program Director and will be our facilitator today. So on today's agenda, we will do some brief introductions and announcements, a didactic presentation on hepatitis C testing recommendations for children by Dr. Alfaro Cruz. We will do a couple of case presentations, one adult case, one pediatric case, and then open it up to, of course, questions throughout. If you have any questions during the presentation, please just put it in the chat, raise your hand, come off of mute. It's pretty informal, so don't hesitate to ask those questions. And then we'll close out with a couple of simple reminders. First, let's take just a couple of minutes to either scan the QR code or use this link to register for this session through Southeast Age Education and Training Center. As a reminder, they are our accrediting body. They also have lots of additional resources, not only for hepatitis C, but also HIV as well. Really great opportunity to see some of those resources. So please make sure that you register, especially if you are interested in continuing education as well. And thank you, Anastasia, for dropping it in the chat. So we'll pause for just a second while we let folks take a moment to register. And for those of you, as you are registering, if you want to give a thumbs up or some kind of reaction, feel free to do so. So I know we have a few people that have registered. Awesome. I see one. So I'll give it another minute. See if we can get a few other folks registered. All right. Thank you. So now we will move into some introductions and kind of just some announcements. So starting with introductions, if you will share in the chat your name, your role, your organization, and whether or not this is your first echo session with us. That would be great. Anastasia already dropped her information in the chat and is here to support you with any technical issues, so don't hesitate to reach out to her. There we go. I'm starting to see some of those introductions and a few familiar faces or names. So really excited to have you here. Yay, someone's first echo session. Welcome. We're so excited to have you. Andrea, look like welcome. Awesome. Really excited to have everyone today. And with that, that kind of closes out our introduction piece. So we can get started with our first didactic, or rather our didactic before case presentations. So Dr. Alfaro Cruz, I will hand it off to you to go over hepatitis C testing recommendations for kids.
Hi, good afternoon, everyone. Thank you for being us here today. So we are going to talk about hepatitis C testing recommendations for children. I am Dr. Alfaro Cruz. I'm a pediatric gastroenterologist, hepatologist at East Tennessee State University. And let's start this. Next slide, please. I have no financial disclosures or conflict of interest to report. Next slide, please. So why is so important? Why do we meet 2 times a month to talk about Hep C, not only in adults, but in children? So far, we know that about 115 million people get infected in the world every year. 11 million of those are actually less than 15 years of age. And one of the main things is that with chronic Hep C infection, it can lead to severe liver disease and other complications that increase mortality and morbidity in children and in adults. Just in the United States, we are estimating that we spend between $200 and $336 million every year related to Hep C testing and Hep C treatment. But the emotional burden of having this diagnosis, as well as complications that can derive from this diagnosis, are definitely more difficult to estimate. Next slide, please. In children, most of the time when we talked about transmission of Hep C, we're thinking that the majority is related to perinatal transmission. We know that there is an incidence between 1 and 7% in Hep C RNA positive mothers that they can actually transmit the virus to their child. And especially, this is actually an increased risk when they have a high Hep C viral load. And it's usually transmitted at the time of labor. There is also an increased risk in mothers who have untreated HIV co-infections that this actually can double the rate of transmission. In adolescents, we tend to see also some cases regarding IV drug use as they share needles, and sometimes they can get infected not only with Hep C, but also as well as HIV. Next slide, please. So as we talked about it, usually in children, kind of how things will progress is we have a mom who has a Hep C infection. There is vertical transmission at the time of delivery, and there can happen, two things can happen in that infant who gets exposed in utero to Hep C. One, there is a spontaneous clearance where his immune system actually fight, the infant does not get the disease, and there's no issues with that children. The other route that can happen of exposure to Hep C during pregnancy is that it can actually progress into disease, where the child or the infant will get into or develop Hep C chronic infection, and then if not diagnosed and if not diagnosed promptly or treated promptly, then it can lead to chronic liver disease, and it can advance into cirrhosis and potentially the risk when they turn into adults of having liver cancer as well. Next slide, please. So some things that are important to talk about it, especially in children's, is when we talk about what kind of symptoms or signs should we look. And the most important thing that we have to be aware is that most of the children were going to be asymptomatic. Liver disease is very uncommon to see during childhood. We only have seen a couple of cases of kids that present with cirrhosis or advanced liver disease during the first 10 years of life. So the expectation that you're going to see a child or even an adolescent with severe liver disease, liver dysfunction, even cirrhosis, it's very, very uncommon. Now, yes, some cases, as we have described, can happen of cirrhosis and fibrosis. And another thing that can be more common in presentation and can be elevated liver enzymes. Now, because we also have been having more issues with unhealthy diet and weight gain, a lot of children may present with obesity or overweight, and that can also lead to elevated liver enzymes. So just something that you have to be mindful when you have a child that presents to your clinic. But what I want you to take out from these talks is that most of the time, we won't see any symptoms in children. Next slide, please. So how do we screen then, right? If we're thinking, okay, we're not seeing significant symptoms in children, what do we do? So a lot of the time, if a child comes into the clinic and you get a liver enzymes and they are elevated, then part of the workup on that child who is overweight and has elevated liver enzymes will actually require to screen for Hep B, for Hep C, for Hep A, and so on. If you know that the infant was born to a mom that was infected with Hep C, or any other siblings of a child who has Hep C, will actually require to be screened. International adoptees or refugees will require to be screened. Things that we have mentioned before in our echo talks is that usually in the US, we know that prenatal care will include screening for Hep C in moms. Now, in other countries, like for example, Latin America or even West Europe, that may not be the case, where the moms are not being screened for Hep C, as it may not be something common in those countries. So you have to be aware that when you are seeing an international adoptee or a refugee, this should be part of the screening that you do. Any child or adolescent that present with a HIV infection, anyone who has been sexually assaulted should need to be screened as well. And then those who we know or are seeking for screening for illicit drug use should also as well. Now, remember, screening is universal, right? So you may have adolescents who just come in and want to get screened, and that is also something that you can definitely do, just perform a testing to screen for Hep C. Next slide, please. So how are we doing it, right? So what are we as the Tennessee Department of Health, what are the new testing recommendations for children who are born to persons living with Hep C? Now, right now, and this is also now more according to the CDC as well, who actually changed its guidelines this past November 2022. So if a child is born, we know that he was exposed in utero and he was born to a mom who had Hep C virus. You're not going to wait. You're actually going to test that kiddo between 2 and 6 months of age, and you're going to use Hep C viral PCR RNA. Now, the goal is to try to get these kiddos early as possible so we can test, we can screen, and we can provide a diagnosis so they are not lost to follow-up. Now, usually, as you can see, we're using that 2 to 6 months of age because that's when they come usually to their well child checks and get their vaccines at 2, a 4, and a 6 months. So if at any point in time of those well child visits, we can actually get some of that screening test that will be useful. Now, the other is if the child is between 7 and 17 months of age and they have not been previously tested, you can also get a Hep C PCR viral RNA. If the child is more than 18 months or 18 months of age and has not been tested, in this case, we're not going to use the Hep C PCR RNA. We're actually going to use the antibody testing. And we can always order that antibody testing with reflex to an Hep C PCR RNA. As if at 18 months it has a positive antibody, then it automatically will reflex to that PCR RNA. Next slide, please. Now, this is according to the new changes that the CDC did back in 2023. And as I can tell you, it's pretty much the same chart as what we were talking with the Tennessee Department of Health. And it kind of tells you, okay, what are the follow-ups or what are the steps that you're going to be following if that kid is diagnosed. For example, we have that example of a kid who between 2 and 6 months of age who had a positive Hep C PCR RNA and it's not detected, then you know that that kid is not infected and no further follow-up needed regarding Hep C. The kid, the infant will continue following its well child cares as normally they would do. Now, in case they present with a positive Hep C RNA PCR between ages 2 to 6 months, you are going to continue following that child until he gets to the time where we can actually, when he gets to 3 years of age, where we are going to repeat a Hep C PCR RNA to see if he has cleared the infection. And if he has not cleared the infection, then we will proceed to treatment at the age of 3. As the new medications, the new direct-acting antivirals, have been proven to be effective starting at age 3. Now, in those kids who you actually diagnose with a positive Hep C PCR RNA between 2 and 6 months, you're going to keep following as your pediatrician with yearly labs that include a CMP, which will include liver enzymes, and continue their normal well child as expected. Next slide, please. Now, what will happen if a kid that is more than 18 months of age has not previously tested COM and there has been some perinatal exposure, right? So if it's non-reactive, meaning that if you have a negative, if you have no antibodies, then no Hep C infection and no further follow-up needed. If it's reactive, if you are showing a positive Hep C antibody, then it will automatically reflect in the labs to a Hep C PCR RNA. If the Hep C PCR RNA is not detected, then there is no current Hep C infection and no further follow-up is going to be needed on that child. Now, he probably is going to be have a positive antibody for life. So in his case, a Hep C PCR RNA will always be the test of the test to choose. Now, if he has a Hep C RNA that it's detected, and we're gonna kind of follow up the same steps. You're going to continue to monitor that child at 3 years of age. You're gonna repeat a Hep C PCR RNA to make sure he has cleared the infection or not. And if he has not cleared the infection, then we'll proceed with treatment that is pertinent to the genotype and to his infection. Next slide, please. Now, other considerations that the CDC has also talked about it is, for example, those infants and children between the ages of 7 to 17 months who have not previously been tested, you should use a Hep C PCR RNA. You should not use antibody testing in these children. Children that are more than 18 months of age who have not been previously tested, they are the ones who are going to get that Hep C antibody testing with a reflex of Hep C PCR RNA. And all siblings of children who have been exposed to Hep C and that are born to the same mom would actually benefit from testing for Hep C infection, unless we know that the birth parent was treated and was known to be Hep C PCR RNA with that pregnancy. But it's just something to be mindful, as sometimes moms or the partners do not get treated or do not get screened and don't have diagnosis. So it's important, if you have a sibling and you have younger siblings or older siblings, to think about screening those siblings as well. Next slide, please. As part of what the screening of the new guidelines have shown, and I want to kind of make focus our attention on this, is that if you have an infant that is more than 2 months of age with undetectable Hep C RNA PCR, you do not require to do any further follow-up for Hep C. You are not required to repeat any more testing for that kid, as the likelihood of that kid presenting with Hep C infection, it's almost nil for that. Next slide, please. So as physicians, as healthcare providers, and as we are all involved in healthcare in children, when are we required to report? And this is just something very important. So if you have a positive or negative confirmatory assays, like nucleic acid amplification testing or the PCR or Hep C PCR genotype testing, you will have to report that. Any child or any person with a positive Hep C antibody, you will also have to report that. Positive and negative Hep C antibodies in children between age 0 to 36 months will need to be reported. As usually, the state health departments will actually follow up with those kids and who have been tested as well. And if any of the above tests are positive, for example, in a pregnant woman who has a positive test for Hep C, that should need to be reported, as well as other serological markers for Hep A, Hep B, and Hep C with elevated ALT and bilirubin levels will have to be reported as well. Some of the labs where we actually send our kids to get these will actually automatically report this, but it's always be mindful, especially if you're more in a rural or suburban area, about how to report these and how to contact. And you can see here in the slide, and I think if we can put it in the chat too, the link to where you're going to have to be report, or you can submit your report for any Hep C case that is positive. Next slide, please. So what do we do, right? We've talked about the screening. We have talked about what labs you're going to do over those first 3 years. Now, finally, we get to that point that that child is 3 years old. We confirm that he still has a Hep C chronic infection, and then it's going to lead you to get a genotype. Now, these genotypes can be between 1 to 6, which we have 6 genotypes. And now with our new medications that are usually able to treat, in the case of Epclusa and Mavyret, all genotypes, and Harmony can treat 4 of these 6 genotypes, then that's what's going to help you decide which medication to use. Now, it's important to know that liver biopsy, it's not indicated in children in order to start treatment. You will need to do a subsequent evaluation to check for Hep B in patients, obtaining a Hep B surface antigen, a Hep B core antibody, and a Hep B surface antibody. Check for HIV infections and also check for a Hep A infection as well. But the most important thing here will be that you don't need to send that kid for a liver biopsy, and it won't delay any options of treatment once they turn 3 years of age. Next slide, please. During that process of that you are waiting to see if that child has cleared the infection or not, between that moment of diagnosis and then treatment, you're going to monitor for disease progression. You can actually be following that patient every 6 to 12 months in your clinic, obtaining ALT and AST to make sure they are within normal levels, and to assure the parents regarding any issues or concerns about advanced liver disease, providing also physical exams to assess liver size, spleen size, and so on. Next slide, please. So serial testing for Hep C, right? And that's something that we are always asked frequently. What if we happen to diagnose a child at 2 months of age? Do we need to kind of get more Hep C viral pcRNAs until they turn 3? And the answer is really not required. It's not required for you to keep testing that child. There are some exceptions as well in case, you start seeing that ALT is going up, or it's going up, or it's decreasing, or it goes back to normal. In that case, you may actually want to measure a Hep C viral PCR RNA to see if he has spontaneously cleared the Hep C infection. But otherwise, once we get to 3 years of age, that's when we're going to repeat the Hep C viral PCR, because that will actually be the age when we definitely decide we are going to treat, and we need to confirm whether the child has active Hep C or not before starting treatment. So those will be the 2 cases where you can actually do serial testing to assess for eradication. Next slide, please. So I always put these slides when we talk about screening, treatment, and management, because it's important to provide educations to our parents. A lot of the problems with Hep C, and it's kind of a social stigma about the kid is infected, we don't want to disclose, should we disclose or not? So I always say it's important to educate them, because this is actually not transmitted. Hep C is not transmitted by casual contact. And so really children do not pose a risk to other children, and they can participate in all school, sports, athletic activities, parties. They can engage in all childhood activities without any restrictions. I always tell parents they don't even have to disclose this to school if they don't want to, right? This is not something that they are going to be transmitted to other children and even other persons in the household. I always say, you have to take the universal precautions that you would follow at school, at home, especially when you're, use, or there's some bleeding or blood exposure. You're going to use techniques such as avoid that blood exposure, not sharing toothbrushes, razors, nail clippers, using gloves or bleach to clean up blood. But that should be universal precautions. This is important because a lot of times the parents are afraid and confused, and they want to limit or not expose that child to be around other people. And that should not be the case. Hep C is not something that child should be even concerned of limiting his interactions and activity, as it's now something that we can actually treat and cure for sure. Now, I always tell the parents, right? Even if we cure the disease, he is at risk of actually getting infected in the future, as he would do if he has unprotected sex, if he has IV drugs used, he had any blood exposure, sexual exposure that can perform. I always tell them, and even if we treat it and cure the disease, that does not provide an indefinite cure if he gets reinfected again. Next slide, please. Any questions so far of what we have talked about testing recommendations?
Thank you.
And I see Nia put the link for the reportable diseases. That is very important. As I'm telling you, some laboratories will automatically do it, but in some areas where we have more limited resources, we may need your help in actually reporting those positive or negative cases.
Yes, great point. We always appreciate being able to connect individuals to resources and can't do that if we don't know their status. And same for clients as well. So we will pause for a moment. Questions related to this, please feel free to drop it in the chat or come off of mute and ask your question. So while we're thinking about some of those questions, I'm going to attempt to launch a poll within Zoom. So we'll see if you all can see this. And we will do some questions this way. Do you all see it on your screen if someone wants to give me a thumbs up? I do, yay, okay. So some of these are just general questions, open-ended questions. Some of them are review related to the topics that we talked about today so far. They're really short, there's only 7, so we'll give it a moment to answer some of these questions. Oh, it looks like the 7th question is actually blank, so don't even worry about that one. That'll be an easy answer. I see a couple of responses coming in. Do you all see the live responses as they come in too, or is that just no? Okay.
No, I think you're the only one who can see them.
Okay, that's fine. Anastasia, question for you. How do I share these with everybody now?
It'll be when you end the poll.
Okay, perfect. I'll give it just another moment. It looks like we're still waiting on a few people to respond, and then we can talk through these. Okay, I'll go ahead and end it. Thank you for those that participated. This is our first time using polls within Zoom. So now I will share. Now you can see the results, right? Yes. Okay, great. So the first question was, are there any questions related to this? And so let's see. Hopefully I'll be able to pull these up. Oh, it looks like it's going to make me sign in. Let me come back to those. So question 2, if a client is presenting and they were adopted from another country, would you choose to screen this child for hepatitis C? So the majority of people said yes. A few people said maybe. And Dr. Alfaro Cruz, you touched on this a little bit. Anybody want to say what their thoughts were as to why maybe they answered maybe? Or why they answered yes, for that matter? Anybody want to add to their answer before we have Dr. Alfaro Cruz comment on it?
You probably aren't going to have the records to know if they've been screened. And if you do have the health records on that patient, they're probably not going to be in English. So having worked with some immigrant population in the past, it's going to be a whole lot easier to repeat some labs than to try to get the labs translated.
Yeah, I think, as you mentioned, that's one of the things that we encounter. A lot of the times, the documentation that they bring will be in a different language as well. So most of the time, it will kind of be easier to just repeat the screening for these patients. Now, depending on also where they're coming from, they may not routinely get tested or get screened for Hep C. So I think that would kind of point more towards having those patients being tested. Now, in the cases where they bring all the information, it's in English, we have documented testing that it's negative, then those cases you may not want to repeat it. You may not need it, especially if there's normal liver enzymes. But most of the time we will ask adoptees from other countries or refugees from other countries to get the screening test.
All right. Yes, thank you. And let's see. Question 3. What's the earliest age you can test an infant known with a known hepatitis C exposure for hepatitis C RNA? And so majority of individuals answered 2 months, which is correct. It's 2 months, 2 to 6 months really, but the earliest would be 2 months. And it's really encouraged to go ahead and test them early, so we can keep them engaged in care and continuing to follow up. Question 8, after it's determined an 8-month-old infant has hepatitis C, what monitoring measures would you plan for that client until treatment can be started? So unfortunately, it looks like a lot of people answered this, which I love. Unfortunately, I'm having technical difficulties in reviewing those answers. So if anybody wants to come off of mute and share what they said for this, that would be awesome. I know at least 8 people put an answer. And you can feel free to put your answers in the chat too.
Hey, Mia, it's Candy. I put none unless the ALT was needed. Is that right?
So usually physical exam, ALT, AST, if needed, you can definitely use those. Usually they will come for the well-child checkup at 9 months, at 18 months, a year and 18 months, and then at 2 years. So unless you need to repeat an ALT, but otherwise you'll just kind of keep doing their physical exams as usual.
And what is the earliest age that you can start treatment for a child? Looks like lots of people answered this, 10. Anybody want to shout it out or put it in the chat? I see some answers coming in. 3 years old, that is correct. And our last question, which of the below are considered reportable? Checking all that apply. So RNA results, whether they're positive or negative, are reportable. The first piece here, the anti-HCV or antibody results, currently for Tennessee, only positive results are reportable. However, if you want to share negative results, we're always happy to have them. But technically, it's positive results that will be reportable. So awesome. Thanks for helping with the poll and participating. We will aim to find the results that people put online too and share those potentially later or in another session. A couple of us have tried and are still having issues with the open-ended questions, so I am sorry about that. If you do have additional questions though related to the didactic, feel free to drop them in the chat or bring them up. But for the time being, and in the interest of time, we will go to the next slide.